In this presentation, we briefly describe the most prevalent psychiatric disorders that the minister may encounter in the congregation. We include the following disorder categories: anxiety disorders, mood disorders, psychotic disorders, neurocognitive disorders, and somatic symptom disorders. Anxiety problems and chronic worries or fears are among the most frequent counseling problems reported as reasons for counseling. Anxiety is a universal human emotion. It is a general feeling of apprehension about possible danger. Nearly all human beings experience anxiety from time to time, and research indicates that some anxiety may be optimal for many kinds of tasks and performances. It is only when anxiety becomes overwhelming or chronic that it may be classified as an anxiety disorder. Like all human emotions, anxiety has three primary components: physiological, subjective, and behavioral. The physiological symptoms are those nervous system responses that are normally triggered in all of us when exposed to a sudden threat. These symptoms include sweating, rapid heart rate, shortness of breath, nausea, dizziness, hot or cold flashes, trembling, dry mouth, or difficulty swallowing. Although anxiety disorders include a range of specific and distinct syndromes, they are united by the underlying presence of fear or panic as the core emotional state. Panic involves the activation of the autonomic nervous system and a number of very primitive self-protective bodily responses, whereas anxiety is more of a diffuse emotional state characterized by worry, unrest, and a less specific sense of danger. Parishioners with anxiety disorders may be fearful of specific situations and objects, and each of the disorders is characterized by irrational and excessive evaluation of the danger these situations present. As a pastoral counselor, it is critical to communicate to the parishioner that anxiety disorders are highly treatable and that effective treatment is often quite brief. Helping the person to realize that the experience of anxiety is neither abnormal nor catastrophic is an important starting place. A calm and reassuring demeanor is always indicated when exploring the experience of anxiety with a parishioner. In nearly every case of anxiety, a referral to a physician is recommended with parishioners who have extreme and unrelenting anxiety. Certain cardiogenic, neurologic, and endocrine-based illnesses may produce anxiety symptoms that may mimic these psychiatric problems. Once these potential problems are ruled out, referral to a mental health professional with expertise in treating anxiety disorders is recommended. Mood disorders are among the most common of all mental health problems in the United States. The most prominent symptom is a disturbance of mood that is intense and persistent enough to be clearly maladaptive. In each of the major mood disorder types, the parishioner will suffer extremes of emotion. This is sometimes called affect. These emotions dominate his or her appearance and behavior. These emotional extremes may range from soaring elation to mania to deep depression. Depression refers to feelings of extreme sadness and dejection, and mania refers to an experience of intense, unrealistic excitement and euphoria. Most parishioners and ministers will experience periods of depressed mood during their lifetime. This is called normal depression and is quite common and is most often associated with some sort of life stress following episodes of loss, such as the death of a loved one, divorce, retirement, job loss, separation from a friend. Depressed mood related to grief and normal adjustment is reasonably ordinary and would not be considered indicative of a psychiatric problem. In the case of mild forms of depression, the pastoral counselor must consider how well prepared he or she feels to counsel a parishioner with mood problems. Good social support, good insight about the problem, and a willingness to seek and engage in assistance to the church are all positive indicators. In cases of more serious mood problems, such as major depression and bipolar disorder, the minister should always encourage the parishioner and the parishioner's family to pursue professional mental health treatment. A joint referral to a physician, preferably a psychiatrist, and a mental health provider with expertise in psychotherapy for mood disorders is highly recommended. It is quite likely that antidepressant medications will be prescribed for the person with a major depressive episode. Psychotic disorders are extremely serious. They are chronic mental health afflictions. As a minister, you may be the first to recognize signs of psychosis in a parishioner. You may be the one to organize and leverage hospitalization for seriously disorganized and potentially dangerous person. More often, you may be called upon to support the person's family as they struggle to understand the gravity of their loved one's illness. Alleviating guilt and shame for the family is important, as parents often assume that they have caused schizophrenia in their child. Helping the family to understand the potent genetic and biological contributions to psychosis, the need for psychiatric treatment, and the long-term nature of the disorder are critical tasks. Research has shown that helpful communities for schizophrenic persons are gentle, accepting, consistent, and knowledgeable about the signs and treatment of the disorder. Larger churches or groups of churches might consider establishing day treatment or support programs for schizophrenic members and their families. The minister should keep in mind that psychiatric medications are typically a must in the effective treatment of these disorders, and that hospitalization can be critical as well. Understanding the chronic nature of schizophrenia while also maintaining and expressing hope for recovery is essential. Neurocognitive disorders or organic mental health problems may be among the most tragic and difficult for the minister and the family members to address, because these disorders involve the structure and functioning in the brain itself, and they are sometimes not treatable. Perhaps the most important task for the minister is helping brain-impaired parishioners and their families with acceptance, helping young parents accept the cognitive limitations of a brain-injured child, helping adult children accept the steady and permanent decline of a parent with Alzheimer's, and helping a spouse accept the steady loss of functioning in a spouse with early dementia are examples of this task. Modeling patient acceptance and sturdy faith in the face of such adversity can be powerful interventions. Serving as an effective referral source is another critical pastoral role. As a minister, you may be the first to recognize the signs of a stroke or subtle head injury and should initiate an immediate referral to a physician. You may be the first to spot signs of caretaker stress in the spouse of a parishioner with dementia. In this case, you might want to recommend a daycare facility for such impaired church members, or even work with a local church to create a daycare consortium for Alzheimer's patients. Somatic symptoms were first discussed by Freud and the psychoanalysts. The term hysteria was first used to capture certain somatic presentations. It is possible that parishioners with somatic disorders are struggling with unconscious sources of anxiety that happen to find expression in bodily symptoms and complaints. Psychodynamic therapy may help these parishioners to explore their psychological conflicts generating somatic symptoms. Cognitive behavioral therapies are often useful for relieving this underlying health anxiety by helping sufferers to question their illness and interpret their bodily reactions in more rational terms. Also, raising levels of serotonin in the brain through the use of SSRI antidepressants may be useful in extreme cases of rumination and obsessiveness. When a minister learns that a parishioner has experienced or witnessed a traumatic life event, it is wise to review the symptoms of the acute stress disorder with the expectation of encountering symptoms of dissociation, avoidance, heightened anxiety, and arousal. Parishioners may feel as though they're going crazy, and they may be ashamed about their level of fear following the experience. Normalizing post-trauma symptoms is the first step, followed closely by an invitation to meet with the parishioner to hear his or her story. When a group of parishioners are involved in a traumatic event, arranging a formal debriefing by a professional experienced with this procedure is recommended. Keep in mind that prompt intervention following a traumatic event is the most effective method of reducing the risk of eventual PTSD. Be sure to avoid frustration with traumatized parishioners who seem unable to quell symptoms such as flashbacks, hypervigilance, and occasional anger when startled or triggered by events around them. When a parishioner appears to suffer inexplicable gaps in memory, or to have an altered personality, or there are others from whom report this, we recommend rapid referral to a practitioner who is well trained and experienced in the treatment of dissociative disorders. Substance use disorders are among the most common and costly disorders the minister is likely to face. In fact, abuse of and dependence on alcohol or drugs may be one of the most under-identified yet widespread problems in the church today. The causes of substance misuse and dependence range from genetic predisposition to social pressure and intentional experimentation. The minister may first become aware of a substance disorder through family members of the addicted person. Physical abuse, neglect of family or a spouse, financial distress, and occupational troubles may all be initial markers of substance-induced impairment. Because denial of the problem is a hallmark symptom of chemical impairment, the minister may play a critical role in empowering those who love the addict or alcoholic to organize a clear confrontation with the person about his or her substance problem. Family members must focus on what the person will have to do to remain in the home and salvage his or her job and relationship. It is best if this intervention is arranged by a professional who is trained in the treatment of substance use disorders. Treatment in severe cases may begin with hospitalization to manage the most severe symptoms of physical and psychological withdrawal from the substance. This will typically be followed by outpatient treatment designed to keep the individual completely abstinent from substances while focusing on a program of counseling and social support from others recovering from dependency. Many churches host meetings of Alcoholics Anonymous or other substance-related disorder recovery groups. This is often an excellent way for the church to blend stewardship, ministry, counseling, and discipleship. Because alcoholism and other forms of substance dependence are chronic problems, the dependent person is always at risk for a relapse. The minister and family members will need to remain vigilant for signs of continued use. The minister will also need to support and empower loved ones in their attempts at setting limits with substance dependent person. The paranoid parishioner is unlikely to approach the pastor for assistance with his or her disorder. Instead, the paranoid person will complain about other parishioners, a spouse, family members, co-workers, and may even vent anger at the pastor. This person tends to view others as against him and will be extremely distrustful of the pastor and most others in the church. Religiously, a paranoid person may be among the most rigid and dogmatic in the church, yet his or her faith tends to be legalistic, formalized, and lacking depth. The pastor may be shocked by this parishioner's apparent lack of insight as he or she tends to be extremely critical of others, but sees no fault in him or herself. He or she may become angry and blame others in the church, perhaps engaging in angry outbursts that disturb others. As you might surmise, the paranoid person is exceptionally difficult to manage and seemingly impossible to help. The minister should remain honest, consistent, and should avoid criticism as much as possible. Still, the minister should recognize that establishing a relationship with a paranoid person is extremely difficult and takes a significant amount of time. Very often, a paranoid person will terminate relationship or leave the church altogether before the pastor senses that any real change has occurred. The narcissistic parishioner will most likely be disliked by most people with whom he or she comes in contact. Although a favorable and even awe-inspiring first impression may be created, those who spend time with the narcissist begin to experience him or her as increasingly arrogant, obnoxiously self-focused, and egotistical. These parishioners will rarely seek treatment or pastoral counseling because they view themselves as perfect or nearly perfect. They tend to blame others and view those around them as failing to understand their talents or as being jealous of them. Referrals for therapy are generally not likely to be helpful. Not only do narcissistic persons rarely follow through with treatment, there is no significant evidence that they benefit from any form of intervention. Firm goal setting, gentle but consistent feedback, and perhaps counseling for the narcissistic spouse and family may be useful. As is the case with all the personality disorders, it is not realistic to expect that the obsessive-compulsive parishioner will make marked changes in his or her basic personality style. Rather than asking an obsessive-compulsive person to give up his or her perfectionistic behaviors. On occasion, the obsessive-compulsive parishioner will be consumed with fear of committing or preoccupation with avoiding a grievous sin. He or she may be rigid in making moral judgments about himself or herself and others. It is often difficult for the pastor to develop much of a relationship with these parishioners, as they may only seek the pastor out when looking for correct or certain solutions to theological or task-focused questions. They may be very disappointed or even agitated if certainty is not offered. Psychotherapy and counseling are not typically sought out or continued by the person with obsessive-compulsive personality, and prognosis for change is guarded at best. However, as in the case with obsessive-compulsive disorder, cognitive behavioral treatments may be helpful for changing at least some of the person's erroneous beliefs and decreasing some compulsive behaviors.